Welcome to the Deep Dive, where we cut through the noise, unpack complex topics, and distill the most critical insights for you, our discerning listeners in the medical community. Today, we're diving deep into an orthopedic injury that, well, while not incredibly common, certainly carries significant functional implications. We're talking about biceps tendon ruptures, and we'll be focusing particularly on the challenging distal biceps avulsion right at the elbow. Our mission today is really to transform your understanding of this condition, equipping you with a comprehensive and, importantly, current overview for your clinical practice. And to guide us through these intricacies, we're incredibly fortunate to be joined by Professor Mo Imam, a distinguished expert with extensive clinical experience and a real wealth of knowledge in this field. Thank you for being with us. Throughout this deep dive, we'll journey through the intricate anatomy of the biceps first. Then we'll identify who is most affected by these injuries, explore the typical ways they happen, the mechanisms of rupture, and look at exactly how these tears are diagnosed. We'll then pivot to the full spectrum of treatment options, from conservative management right through to the latest surgical techniques. And we'll finish by delving into rehabilitation, expected outcomes, and the absolutely critical role of the interprofessional healthcare team. It's a lot to cover, but it's essential stuff for anyone dealing with these injuries. All right, let's unpack this then. Before we get into the ruptures themselves, it's really vital to have a crystal clear understanding of the structure we're discussing. Most of us are familiar with the biceps muscle, of course, but its anatomy, particularly around the elbow, is quite specific. And it's this specificity, isn't it, that often dictates the injury patterns and the subsequent management.
Absolutely, that's right. The biceps brachii muscle is anatomically quite unique, actually, fundamentally different from many other muscles. It originates from two distinct heads up near the shoulder. You've got the short head, which arises from the coracoid process, that sort of hook-like projection of the scapula. And then there's the long head, which originates from the supraglenoid tubercle of the scapula and also contributes from the superior labrum. These two muscle bellies then converge in the upper arm, forming a single, pretty robust distal biceps tendon.
Right, so it comes together into one main structure distally.
Exactly. This singular tendon then travels down the arm, crosses the elbow joint, and inserts onto the radial tuberosity, which is a distinct bony prominence on the radius bone in the forearm. It's this rather intricate arrangement, the dual origin converging to a single insertion, that gives the biceps its remarkable versatility and, well, its power.
And what are its primary roles in arm function then? Particularly given that crucial distal attachment to the radius, how do those roles make it so clinically important when it gets injured?
Well, its main functions are powerful forearm supination. That's the motion of rotating your palm upwards, as if you're turning a doorknob or using a screwdriver.
Okay.
And elbow flexion, simply bending the elbow. While both are important, it's often the supination that is most significantly compromised with a distal rupture. And arguably, that's the most functionally debilitating loss for many patients.
I see.
The long head also plays a more subtle yet important role in contributing to the stability of the glenohumeral joint at the shoulder. So understanding these distinct biomechanical contributions is absolutely key, because a rupture, particularly a distal one, profoundly impairs these specific movements. And it's also worth mentioning the bicipital aponeurosis, or lacertus fibrosis. This is a sort of fibrous band originating from the short head that passes obliquely across the cubital fossa.
Right, that flat tendinous sheet.
Precisely. And crucially, if this band remains intact, even with a complete biceps tendon rupture, it can sometimes mask the full extent of the tear clinically, or even minimize the functional deficits someone experiences.
Ah, so it can make diagnosis trickier.
It certainly can. It might complicate the initial clinical assessment, maybe delay the diagnosis.
Yeah.
So it's a detail we must always be mindful of during examination.
That nuanced understanding of the biceps' unique anatomy, especially its distal attachment and that lacertus fibrosis, really sets the stage. But it also makes me wonder, who exactly are we seeing these injuries in? Is it always the sort of weekend warrior type or the professional athlete? Or is there a broader demographic we need to keep an eye on as clinicians?
That's an excellent question, and it really speaks to the epidemiology of these injuries. Research suggests that distal biceps tendon ruptures are relatively uncommon. The incidence rate is around 2.55 per 100,000 patient years. So, they are far less frequent than, say, rotator cuff tears or Achilles tendon ruptures.
Okay, so not hugely common then.
No, but their demographic specificity is quite striking. They predominantly affect men. We're talking over 95% of cases are male. And typically these injuries occur in middle age, most commonly between 35 and 54 years old.
Right, in that active working age group.
Exactly. And in the vast majority of these cases, it's the dominant limb that's affected. which makes intuitive sense, really, given the typical mechanisms of injury we'll come on to. Now, in stark contrast, proximal biceps ruptures those involving the tendon closer to the shoulder guiget. They're more frequently seen in older patients, often over 60, and they're usually less functionally impactful.
Okay.
So while it's not a mass phenomenon, the distal rupture affects a very specific demographic that's at highest risk.
I'm particularly curious about the predisposing factors. It feels like these aren't just random events, that there's often a buildup. What are those underlying vulnerabilities we should be looking out for in our patients? Things that might contribute to the tendon susceptibility?
You've hit on a crucial point there. While a sudden eccentric force is indeed the direct mechanism of injury, that's the acute event that causes the tear, several underlying factors contribute to a progressive degeneration and weakening of the tendon over time.
Ah, so it's often weakened beforehand.
Precisely. These factors make the tendon inherently susceptible to rupture, meaning it's often a culmination of cumulative stress rather than just an isolated acute incident happening to a perfectly healthy tendon. For instance, advancing age is a significant factor. Tendons, like other connective tissues, naturally undergo degenerative changes. They become less elastic, less capable of handling repetitive loads, and, well, more brittle with time.
Making them prone to microtrauma.
Exactly. And chronic overuse, particularly in physically demanding jobs involving repetitive heavy lifting, or in sports requiring powerful arm movements, think weightlifting, wrestling, even certain manual labor jobs, that can lead to constant microtrauma and progressive weakening of the tendon's structural integrity. What's particularly striking, though, and perhaps often overlooked, is the impact of certain lifestyle choices. Smoking, for example, is a very significant and, importantly, modifiable risk factor.
Really? How significant?
Well, studies have consistently shown it increases the predisposition to distal biceps tears by about 7.5 times compared to non-smokers.
Wow, that's substantial.
It is, and is primarily attributed to nicotine's deleterious effects on tendon strength. It compromises the blood supply, leading to microvascular insufficiency, and it interferes with collagen synthesis and remodeling. So it's bad news for tendons.
Okay, so smoking is a big one. What else?
Other systemic conditions can also play a role, although perhaps less commonly. Obesity places increased mechanical strain on musculoskeletal structures, including tendons. Prolonged systemic use of corticosteroids, they're known to weaken collagen crosslinks. And more rarely, certain quinolone antibiotics have been implicated. Conditions like diabetes, lupus, and chronic kidney disease can all compromise overall tendon integrity too.
Right.
And from a pathophysiological perspective, the distal biceps tendon has a known vascular watershed zone.
Meaning poor blood supply.
Essentially, yes. Think of it like a remote outpost in terms of blood supply. It's at the very end of the line, getting less robust blood flow compared to other areas. This inherent physiological vulnerability means it struggles to heal efficiently after microtrauma, making it particularly prone to the degenerative changes that precede a rupture. And if you look at torn biceps tendons under the microscope, histopathological studies consistently show changes consistent with tendinopathy. You see an increase in proteoglycans and collagen type 3, disorganized collagen fiber arrangements, altered matrix components.
So the structure is already compromised.
Exactly. These aren't just microscopic curiosities. They explain why the tendon loses its ability to handle tensile load and becomes so prone to rupture. It's like a frayed rope, you see, fundamentally compromised at a cellular level, often long before the acute tear actually happens.
That's a truly comprehensive picture of the predisposing factors. So with that picture of the sort of weakened tendon, what's the straw that breaks the camel's back? What does that moment of injury typically look like and feel like for a patient in that split second?
Well, the classic mechanism for a distal biceps rupture involves an excessive eccentric force. That's applied as the arm is forcibly extended from a flexed, often supinated position.
Okay, so it's being stretched while it's trying to contract.
Precisely. Imagine a patient attempting to lift a very heavy object, perhaps a piece of furniture, a weighty box, maybe even during a strenuous biceps curl at the gym. Suddenly, the weight unexpectedly drops or just exceeds their strength, forcing their flexed arm to rapidly straighten against the resistance.
Right, like catching something heavy that slips.
Exactly that kind of scenario. The biceps, trying desperately to resist this extension, experiences a sudden overwhelming stretch and force, and that leads to the tear. This commonly occurs during activities involving heavy, uncontrolled lifting like deadlifting or certain labor-intensive jobs, or even during contact sports like wrestling or rugby, where the arm might be forced into extension. Patients frequently report an immediate, sharp, often excruciating pain in the elbow. And almost always, it's accompanied by a distinct audible pop or snapping sensation right at the time of injury.
Ah, the pop. You hear that a lot.
You do. That pop is a very characteristic historical finding. Patients often describe it as feeling or hearing something literally tear or snap in their elbow.
So, beyond that acute, often audible event, what does this sudden rupture look like clinically? What signs would a medical professional typically observe upon examination, and how do we distinguish it from other elbow issues?
Right. Well, beyond the acute severe pain, which paradoxically might diminish somewhat after a week or two, even with a complete tear, as the acute inflammation settles down, a key diagnostic sign for a complete distal biceps rupture is the Popeye deformity.
Right, the muscle bunching up.
Exactly. It's a characteristic bulbous mass or bulge in the upper arm, caused by the proximal retraction and shortening of the biceps muscle belly. Essentially, the muscle has lost its distal anchor point and has recoiled upwards. It's often quite visually striking and frequently prompts the patient to seek medical attention. We sometimes call it a reverse Popeye deformity compared to a proximal rupture, where the bulge is lower down. Then, in the antecubital fossa of the elbow, the crease at the front, you typically observe ecchymosis, bruising, indicating bleeding from the tear site, along with swelling and tenderness. And crucially, there will often be a palpable defect where the tendon should normally attach to the radial tuberosity because it's retracted proximally. Feeling that gap is a very strong clinical sign. Now, for proximal biceps ruptures, the presentation is generally less dramatic, usually just involving pain and bruising in the proximal arm and shoulder region. And these rarely result in significant long-term changes in elbow or shoulder strength, mainly because the distal attachment, the key one for supination and powerful flexion, remains intact.
Right, different functional impact.
Very different. It's also important, particularly in the acute setting, to check for any associated shoulder girdle muscle atrophy or signs of shoulder impingement, as proximal biceps tendon disorders are frequently linked to underlying rotator cuff pathology. But the key differentiator for distal ruptures for us as clinicians is that very specific loss of forearm supination power and that pronounced muscle deformity. Those are the real red flags.
Given these clinical presentations, then, how do clinicians definitively diagnose these injuries? Are there specific physical examination tests that are particularly reliable? And how do we ensure we're not missing, say, a partial tear or other conditions that might mimic this?
The diagnosis of a distal biceps rupture is, in many cases, primarily clinical. It's based on a combination of the patient's history and the physical examination findings. We tend to rely on three primary criteria. Firstly, a clear history of a single traumatic event, typically involving that eccentric loading of a flexed elbow, the patient recounting the pop, or that sudden giving way.
Okay, the story fits.
Secondly, those visible and palpable signs of the biceps muscle belly retracting that characteristic reverse Popeye deformity we just discussed. Although, while visually striking, it can sometimes be harder to appreciate in more muscular or obese individuals, so careful palpation is absolutely key. And thirdly, noticeable weakness in both elbow flexion and, critically, forearm supination. The supination deficit is often the most pronounced and functionally significant one.
Right. Are there specific tests you'd perform?
Yes, we rely on specific provocative tests to help confirm the diagnosis and assess the integrity of the tendon. The hook test, for instance, is highly sensitive and specific for distal biceps tendon avulsions.
How does that work?
Okay, so to perform this, the examiner positions the patient's arm at 90 degrees of elbow flexion and asks them to actively fully supinate their forearm. The examiner then attempts to hook their index finger under the lateral edge of the biceps tendon, right in the croup of the elbow. If the tendon is intact, you should be able to hook your finger approximately 1 centimeter beneath it, feeling that taut cord-like structure.
And if it's torn?
If it's completely torn and retracted, you simply can't hook your finger around it. There's nothing there to hook. However, a word of caution. A false positive result can occur.
How so?
Well, if there's a partial tear, you might still feel some structure. Or, more commonly, if the intact lacertus fibrosus, that fibrous band we mentioned, or even the underlying brachialis tendon, is mistaken for the intact biceps tendon. So, meticulous anatomical knowledge and careful palpation are absolutely vital to interpret this test correctly.
Got it. Any other key tests?
Another valuable tool is the Rulin biceps squeeze test. It's somewhat analogous to the Thompson test for Achilles ruptures. This is performed with the patient's elbow supported in about 60 to 80 degrees of flexion and the forearm pronated, so palm down. The examiner then squeezes the distal biceps muscle belly firmly.
And what are you looking for?
In an intact tendon, That squeeze should cause passive supination of the forearm or wrist. If the tendon is torn, a positive test is indicated by the absence of that supination movement. The muscle contracts, but it's not connected to cause the rotation. Additionally, we can look at the biceps crease interval. That's the distance between the antecubital fossa crease and the distal edge of the biceps muscle belly. This distance is typically increased in full-thickness distal biceps tendon ruptures due to the proximal muscle migration. So these tests, combined with the history and the visible deformity, usually provide a very clear clinical picture for a complete tear.
That's a great breakdown of the clinical signs and tests. What role, then, do imaging studies play? Are they needed to confirm the diagnosis or, perhaps more importantly, to guide treatment decisions? Is an MRI always necessary, for example? Or are there situations where other modalities like ultrasound might be more appropriate, perhaps even for distinguishing more subtle findings?
Imaging is certainly an essential adjunct, particularly when the clinical diagnosis is a bit ambiguous. Perhaps in a subacute presentation where the initial swelling has subsided, making the deformity less obvious. Or if a partial rupture is suspected, which could be harder to diagnose clinically. Or if we need to determine the precise degree of tendon retraction for surgical planning, especially in delayed cases.
So, not always needed for a clear-cut case.
Not always for diagnosis alone in a classic acute presentation. Ultrasound is an inexpensive, non-invasive, and readily available option. It can visualize the absence of the tendon in complete ruptures quite well, and it can be very useful at the point of care. However, its accuracy is highly dependent on the operator's skill and experience. It can be less definitive for subtle partial tears or accurately assessing the amount of retraction, so it's not always the gold standard investigation.
And x-rays.
Radiographs, or x-rays, are generally not diagnostic for the soft tissue tear itself. They won't show the tendon rupture, but they are incredibly useful for ruling out other accompanying bony pathologies. For example, an avulsion fracture of the radial tuberosity, where a small piece of bone might have torn away with the tendon, or for surveying for radial tuberosity hypertrophy, which can sometimes be a predisposing factor or impact surgical planning. So they're important baseline images.
Okay, so what about MRI then? When is that really indicated?
Right, MRI. For a straightforward, complete rupture where the clinical picture is very clear from the history and physical examination, an MRI might not be absolutely essential just for the diagnosis. However, it is an incredibly valuable tool when we need to differentiate definitively between a complete and a partial tear, or distinguish between a muscle substance tear versus a true tendon avulsion from the bone, or, crucially, to precisely assess the degree of tendon retraction.
And that retraction detail is key for surgery.
Absolutely critical for surgical planning, especially in delayed or chronic cases where the tendon might have significantly scarred down and retracted far from its insertion point. Knowing how far it's pulled back helps us plan the approach and potential need for grafts. For optimal visualization, particularly in these subtler chronic cases, a specific MRI positioning known as the flexion abduction supination view, or FABS view, is often used.
FABS.
Yes, FABS. This involves positioning the patient's arm in full abduction, sort of up above their head, with the elbow flexed to 90 degrees and the forearm fully supinated. This specific positioning provides a really clear, unobstructed view of the entire course of the distal biceps tendon and its insertion onto the radial tuberosity. It allows for a detailed assessment of the tear pattern and the amount of retraction, which is invaluable for guiding our surgical approach.
That makes sense. So once a definitive diagnosis of a biceps tendon rupture is made clinically or with imaging support, what are the primary treatment pathways? Is surgery always the required course of action? Or are there scenarios where a non-surgical approach is more appropriate for our patients, really acknowledging their individual needs and functional demands?
Right, the chosen management strategy really depends significantly on several critical factors. Primarily, the specific site of the rupture, whether it's proximal up at the shoulder or distal down at the elbow. And equally important are the patient's individual functional demands, their activity level, their age, and their overall health status, including any significant comorbidities that might increase surgical risk. Initial care for any biceps tendon rupture, regardless of location, typically involves conservative measures first, just to manage the acute symptoms and reduce inflammation.
So RC, basically. Rest, ice.
Yeah, exactly. Ice application, supportive elastic bandages to control swelling, non-steroidal anti-inflammatory drugs, NSAIDs, once the immediate bleeding risk has subsided. Of course, to manage pain and inflammation, and relative rest to protect the area during that initial healing phase. Now, for proximal biceps tendon ruptures, those involving the long head of the shoulder, non-surgical treatment is generally sufficient for most patients.
Okay.
These ruptures are more common in older, perhaps less active individuals. And while they may experience some residual cosmetic deformity, that Popeye deformity in the upper arm, or maybe some intermittent biceps muscle cramping, they typically don't suffer significant long-term deficits in shoulder or elbow strength. The short head and other muscles often compensate effectively.
They're not always non-operative.
No, there are exceptions. Younger, more active patients, or those who are significantly concerned about the cosmetic appearance or have persistent bothersome cramping, they might opt for surgical intervention. Specifically, a procedure called biceps tenodesis. This involves reattaching the long head of the biceps tendon to the humerus bone rather than leaving it detached or trying to repair it back in the shoulder joint. And also, the presence of associated rotator cuff pathology can influence the decision towards surgical management for proximal tears, as both conditions can often be addressed concurrently during a single operation.
That's a very clear distinction for the proximal tears. But let's shift our focus back now to those distal ruptures at the elbow, which, as you highlighted, carry much greater functional implications. What are the real options here, and when is surgery truly, well, almost non-negotiable?
Yes, for distal biceps ruptures, the treatment paradigm shifts significantly. These ruptures lead to much more profound and often debilitating functional deficits if they're left untreated surgically. So non-operative treatment for complete distal biceps rupture is generally reserved for a very specific, quite small subset of patients.
Such as?
These would include individuals with very low physical demands on their arm, perhaps a sedentary elderly patient, or those with multiple significant comorbidities that substantially increase surgical risk, making the potential complications of surgery outweigh the functional benefits. Or, simply, individuals who are fully informed and willing to accept a substantial permanent functional deficit in their arm.
And it's crucial they understand that deficit.
Yeah, absolutely crucial. You have to counsel these patients thoroughly and very realistically about the expected long-term outcomes. Studies consistently indicate a potential 50% loss of sustained supination strength.
50%, wow.
Yes, 50% sustained supination strength loss. About a 40% loss of overall peak supination strength, a 30% loss of elbow flexion strength, and approximately 15% loss of grip strength if the tendon isn't surgically repaired. This is a significant functional impairment for many people, impacting everything from turning a key or using tools to lifting everyday objects.
That lack of supination strength sounds particularly disabling.
It really is. Now, if the bicipital aponeurosis, that lacertus fibrosis, remains intact, it can sometimes minimize these functional deficits to some extent in a very low-demand patient. But it rarely, if ever, fully compensates for the loss of the primary distal biceps attachment's power. So in contrast, operative treatment is typically considered the gold standard and is almost always indicated for younger, active patients who are unwilling to sacrifice their arm function.
And the benefits are clear.
The primary benefits of surgical repair are a faster recovery and, crucially, a more complete and reliable restoration of strength, particularly in powerful forearm supination and also effective pain relief in the antecubital fossa. Most surgeons widely recommend surgical repair for complete distal biceps tendon ruptures because of these superior outcomes. It can be offered for acute injuries, meaning those within a few weeks of onset, as well as subacute presentations. And even some chronic ruptures or partial ruptures that have failed conservative management and remain symptomatic can be considered for repair, though it's more complex.
And you mentioned timing earlier.
Yes, crucially, the timing of surgical intervention is paramount. Ideally, it should occur as early as possible, typically within the first 2 to 3 weeks of the injury.
Why so critical?
Because delaying intervention leads to significant tendon retraction and scarring. The tendon pulls back up the arm and gets stuck in scar tissue. This makes primary repair much more challenging, technically demanding, and sometimes impossible without needing extensive grafts to bridge the gap. Beyond 4 to 6 weeks, the tendon can retract so significantly and scar down so densely that primary anatomical repair becomes much, much harder. It requires greater dissection, potentially leading to less optimal outcomes or the definite need for augmentation with a graft.
That's a powerful point. So for our listeners, the critical insight isn't just what to do, but really when to do it. Early referral isn't just good practice. It sounds like it's a potential game changer for reducing complications and maximizing outcomes. Time, in this case, truly equals tendon length and functional recovery potential.
That's exactly right. Prompt diagnosis and referral are key.
Okay, so given that surgical repair is often the gold standard for active individuals with these distal biceps ruptures, could you walk us through the different surgical approaches and maybe the various methods used to actually reattach the tendon to the bone? This is where the technical precision really comes into play, I imagine.
Absolutely, and this is where surgical nuance becomes critical for achieving that good outcome. Surgical repair of the distal biceps tendon can broadly be considered through two conceptual approaches: non-anatomic and anatomic. A non-anatomic approach basically involves suturing the ruptured biceps tendon to the brachialis muscle, which lies just underneath it.
Simpler, perhaps.
It is simpler, and certainly less invasive in some ways, but it primarily aims to regain elbow flexion strength. Crucially, it provides little to no restoration of that powerful forearm supination, which, as we've discussed, is a significant functional deficit for most active patients. So the anatomic approach, which involves reinserting the ruptured tendon directly onto its natural insertion point, the radial tuberosity, is widely preferred. It gives superior results in restoring both powerful elbow flexion and, more importantly, that robust forearm supination strength.
Okay, so anatomic repair is the goal. How do surgeons actually get there? What are the main techniques?
Right, to access the radial tuberosity for this precise anatomic reinsertion, surgeons typically use one of two main techniques, each with its own set of advantages and potential complications that we need to be aware of. Firstly, there's the anterior single incision technique. This involves making a longitudinal incision, usually around 3 to 5 centimeters long, over the anterior aspect of the elbow, typically at or just distal to the elbow crease, the antecubital fossa. Deep dissection is then carefully performed through a specific interval between the brachioradialis muscle, which is retracted laterally to the thumb side, and the pronator teres muscle, which is retracted medially towards the body.
And the risks with that approach?
Well, the most common minor complication with this approach is injury to the lateral antebrachial cutaneous nerve, the LABCN. It runs quite close to the surgical field as it exits between the biceps and brachialis muscles proximal.
What does that cause?
Injury usually results in temporary numbness or paresthesia that pins and needles feeling in the radial aspect of the forearm. It's a sensory deficit, and thankfully it typically resolves spontaneously within about 3 to 6 months as the nerve recovers. The most severe, though rarer, complication is damage to the radial nerve, or, more specifically, its deep motor branch, the posterior interosseous nerve, or POI, that supplies motor function to the wrist and finger extensors.
How do you avoid that?
The POI can be protected by limiting forceful lateral retraction of the brachioradialis muscle, and, crucially, by keeping the forearm maximally supinated throughout the procedure. That maneuver actually moves the nerve away from the surgical field and reduces tension on it. The single incision technique is generally associated with a lower risk of heterotopic ossification and synostosis, compared to the dual incision approach, which was one of its original design advantages when it was refined.
Okay, so what's the dual incision technique then?
Secondly, we have the dual incision technique. This approach was originally developed primarily to try and mitigate the risk of injury to that posterior interosseous nerve, which was a significant concern with earlier single incision methods before nerve protection techniques were fully refined. It involves a smaller anterior incision over the antecubital fossa, similar to the single incision approach, but this is combined with a second, separate posterolateral elbow incision on the back outer side of the elbow. The posterior dissection typically involves navigating the interval between two muscles, the extensor carpi ulnoris, ECU, and the extensor digitorum communis, EDC. After identifying the radial tuberosity anteriorly through the first incision, a blunt curved instrument, like an artery forceps, is used to guide the second incision. You slide it along the medial border of the tuberosity, pierce the anconeus muscle, and tent the skin posterolaterally. This guides the precise location for the second incision.
Allowing access from the back.
Exactly. It allows for direct dorsal access to the radial tuberosity for preparing the bone and placing the fixation device. However, it's worth noting that this dual incision technique has historically been more commonly associated with complications like synostosis.
That bony bridge between the radius and ulna?
Precisely. Synostosis can severely limit forearm rotation, and also heterotopic ossification, which is new bone formation in the soft tissues. Now, these risks can be minimized by meticulously avoiding unnecessary dissection between the radius and ulna bones and by avoiding exposure of the ulnar periosteum, but the risk remains inherently higher than with a careful single incision approach. This historical challenge with dual incision techniques has, in many centers, led to a preference swinging back towards the refined single incision approach with meticulous nerve protection strategies.
That makes sense. So once the surgeon has accessed the site, retrieved the tendon stump, and prepared the radial tuberosity, how is the tendon physically reattached? You mentioned fixation are some methods biomechanically stronger than others. Providing a more robust initial repair must be critical for allowing early rehabilitation, right?
Indeed, the fixation method is absolutely critical and needs to provide a strong, lasting repair, and importantly, one that's secure enough to potentially facilitate early, safe rehabilitation protocols. There are several well-established techniques for fixing the distal biceps tendon back to the bone, each with its own advantages and biomechanical profile. These include fixation through bony tunnels, using suture anchors, interference screws, or a suspensory cortical button.
Okay, could you briefly explain those bony tunnels first?
Right. In the bony tunnel technique, small cortical holes are drilled on the radial side of the tuberosity, and these are then connected to a larger bone tunnel created within the radial tuberosity itself. Sutures are passed through the tendon end, often using a robust locking stitch like a modified Kessler stitch, and then these sutures are passed through the drill holes in the bone. They're finally tied securely over the outer bone surface, thereby pulling and securing the tendon tightly within the tunnel. It's a classic and reliable technique, though perhaps slightly more prone to complications like synostosis if not done meticulously.
And suture anchors.
Suture anchors involve first decorticating the radial tuberosity, essentially removing the superficial, hard outer layer of bone to expose the cancellous, more vascular bone beneath. This creates a rougher, more biologically active surface for the tendon to heal onto, promoting robust biological reattachment. Then, one or two small anchors, typically made of titanium or bioabsorbable material, are screwed or tapped directly into the bone at the insertion site. Sutures preloaded onto these anchors are then passed through the tendon and tied down, securing the tendon firmly against the prepared bone surface. Recent biomechanical studies have generally demonstrated superior pull-out strength with suture anchors compared to the traditional bony tunnels, offering excellent initial fixation.
Interference screws. How do they work?
Interference screws alone have shown pull-out strengths that are stronger than suture anchors in some studies, but generally weaker than the cortical button method. The interference screw technique involves passing sutures through the tendon end first. These sutures are then secured within a prepared bone tunnel using a bioabsorbable screw. The screw essentially wedges the tendon stump and its sutures tightly into the bone tunnel, providing compression fixation. The design of an interference screw repair is intended to closely resemble the stiffness and strength of a healthy, native tendon insertion, hopefully promoting natural healing under tension.
And finally, the cortical button. You mentioned that was strong.
Yes, the suspensory cortical button, often referred to by brand names like Endo button, has consistently demonstrated the highest initial fixation strength in numerous biomechanical experiments. It's proven superior in terms of failure load, ultimate stress distribution, and stiffness compared to transosseous sutures, bone tunnels, interference screws, and even many suture anchor designs.
How is that achieved?
This method involves drilling a small tunnel completely through both cortices of the radius bone at the tuberosity. The tendon end, which has been pre-sutured, often incorporating the button itself into the suture construct, is passed through this tunnel. The small metal button is then flipped or deployed on the far cortex, the outer side of the bone, creating a very strong cortical purchase, like a toggle bolt. Tension is then applied to the sutures, pulling the tendon stump firmly down into the bone tunnel created in the radial tuberosity. It provides very secure fixation.
Can you combine techniques?
Yes, absolutely. It's important to note that a combination of techniques, such as using a suture button for the primary cortical fixation, combined with an interference screw within the tunnel for added compression and aperture fixation, has been shown in biomechanical studies to provide the strongest overall fixation, leveraging the benefits of both methods. The choice among these methods often depends on the surgeon's experience, their preference, and the specific characteristics of the tear. Things like tendon quality, the amount of tendon retraction, and the presence of any associated bony fragments.
What about those chronic ruptures you mentioned? Are they treated differently?
Yes, for chronic ruptures, which are typically defined as tears that are more than 4 weeks old, the situation can be significantly more challenging. This is due to that pronounced tendon retraction and the formation of dense scar tissue around the stump and in the path of the tendon. While primary anatomical tendon fixation might still be feasible, sometimes by hyperflexing the elbow during surgery to gain sufficient length and reduce tension on the repair, it often requires augmentation.
Augmentation with what?
With either autograft tendon taken from the patient themselves, like a hamstring tendon, or more commonly allograft material, which is donor tendon tissue. This is used to bridge the gap between the retracted native tendon and the radial tuberosity, providing adequate length and strength for a tension-free repair. Common graft choices include fascia lata, semitendinosus tendon, or even Achilles tendon allograft. While these grafts can provide excellent outcomes in experienced hands, primary anatomical repair is generally preferred whenever possible. Non-anatomic repairs, like suturing to the brachialis in chronic cases, have historically shown a lower success rate, maybe only around 60%, and result in significantly less supination strength restoration.
Okay, that's very clear on the surgical side. Now, with any surgical intervention, there are inherent risks, and it's vital for us as medical professionals to be fully aware of them for appropriate patient counseling and risk management. What are the common and perhaps the more severe complications associated with distal biceps tendon repair, and what factors most influence their occurrence?
Right, it's crucial to discuss risks. While the overall complication rate for distal biceps tendon repair is reported to be around 25%, it's important to frame this by stating that most of these complications are actually minor and transient, resolving without long-term issues. The most common minor complication, with an incidence of about 9%, is injury to that nerve we mentioned earlier, the lateral antebrachial cutaneous nerve, or LABCN.
From the retraction during surgery.
Often, yes, due to retraction during the anterior surgical approach. Clinically, this presents as temporary numbness or paresthesia, that tingling sensation in the forearm, usually in the radial forearm distribution. Fortunately, this sensory deficit typically resolves spontaneously within 3 to 6 months as the nerve recovers or adapts. It's usually more of a nuisance than a major problem.
What about more serious complications?
More severe, though less frequent, complications include injury to the radial nerve, or more specifically its motor branch, the posterior interosseous nerve, the PN. The P is the most commonly injured motor nerve during these procedures, but the incidence is still low, around 1 to 2%.
And that causes weakness.
Yes, typically resulting in weakness or loss of finger and wrist extension. These motor nerve injuries are generally considered more common with the single incision technique if adequate nerve protection isn't meticulously maintained, and historically also with the dual incision approach. But the good news is, like the sensory nerve issues, they also tend to resolve spontaneously within 3 to 6 months in most cases. Superficial radial nerve injury is another potential, though less common, cutaneous nerve complication.
Are there other significant issues besides nerve injuries?
Yes, other significant complications involve new bone formation around the repair site. Firstly, heterotopic ossification, where new bone develops abnormally in the soft tissues around the elbow. This is actually found radiographically in over 1/3 of patients post-surgery.
That sounds quite common. Is it a problem?
While common on X-ray, it is often asymptomatic and doesn't significantly affect functional outcome unless it's quite extensive and physically impinges on structures or joint movement. It's a known risk if the interosseous membrane between the radius and ulna, or the ulnar periosteum, are inadvertently disrupted during dissection, as these tissues have osteogenic potential. Synostosis is a much more severe, and thankfully much rarer, form of new bone formation. This involves the creation of a bony bridge directly between the radius and ulna bone.
And that blocks rotation.
Exactly. This is a very serious complication because it can severely restrict or even entirely eliminate forearm pronation and supination, profoundly impacting arm function. It can occur from drilling excessively large bone tunnels, through suture rupture allowing bone-on-bone contact when using the bone tunnel technique, or, as mentioned, it was historically more common with the dual incision technique due to the wider dissection needed between the radius and ulna. It can be minimized by meticulously avoiding dissection between the radius and ulna bones and avoiding exposure of the ulnar periosteum.
What about the repair itself failing? Re-ruptures.
Re-ruptures of the repaired tendon are relatively rare, thankfully. The reported rate is generally about 1–2%, which is quite reassuring for patients undergoing this procedure. However, it's worth noting some studies looking at specific fixation methods, such as suture anchors used alone without additional support, have reported slightly higher re-rupture rates, maybe around 5% in some series.
And does timing matter for complications too?
Yes, absolutely. A critical factor influencing overall complication rates, right across the board, is the timing of the surgical intervention. Early intervention, ideally within those first 2 to 3 weeks of the injury, has been clearly shown to substantially decrease the risk of complications compared to delayed repair.
How much difference does it make?
Well, for instance, complication rates can potentially rise from around 20% in acute cases to as high as 40% if surgery is delayed beyond 2 or 3 weeks. This really underscores the importance of prompt diagnosis and referral. And of course, meticulous surgical technique, including thorough debridement of any bone debris from drilling, copious irrigation to wash out any loose bone fragments, and careful atraumatic use of retractors to protect nerves and soft tissues is absolutely paramount to mitigating all these risks.
Okay. Moving to a more positive outlook now, what can patients generally expect in terms of their recovery and long-term function after a successful surgical repair of a distal biceps tendon rupture? What's a typical prognosis that we can confidently share with our patients, giving them a realistic expectation for their return to function?
Well, the good news is that the prognosis for patients undergoing timely surgical repair of a distal biceps rupture is generally very good to excellent, which is of course why operative treatment is so often recommended for active individuals. Most patients can expect to regain an excellent functional outcome. They often achieve near normal range of motion and strength within approximately 4 to 6 months following surgery.
4 to 6 months for good function.
Yes, for good functional recovery. Now, while complete recovery of strength and endurance, particularly for very heavy repetitive tasks or high-level sport, may take longer, perhaps up to a year, nearly all patients achieve a highly satisfactory functional outcome eventually. Specifically looking at strength measures, both elbow flexion and, importantly, forearm supination strength typically recover to about 90% of the uninjured side.
90% is pretty good.
It's a remarkable restoration of power, yes, and it allows patients to return to most activities requiring strong arm function. This means a reasonable expectation for most people of returning to heavy activities, manual labor jobs, and participation in sports that require robust arm function. And this stands in stark contrast to non-operative treatment, which, as we discussed, leads to significantly inferior strength restoration and persistent functional deficits, especially in that critical supination movement. That's a major compromise for many daily tasks and occupations.
So the message is clear for active patients.
Absolutely. For young, active patients, timely diagnosis and surgical intervention are really critical to achieving these optimal long-term functional outcomes and avoiding significant long-term disability.
That's incredibly reassuring to hear about the potential outcomes. Let's transition now to the patient's journey after the surgery. What does the typical postoperative care and rehabilitation protocol entail following a distal biceps tendon repair? And how crucial is patient adherence to this plan for actually achieving those optimal outcomes we just discussed?
Yes, the postoperative phase and the subsequent rehabilitation are absolutely critical. They are essential for translating a technically successful surgery into a truly successful functional outcome for the patient. Post-surgery, the arm is usually immobilized for a brief period, typically just for comfort and initial protection of the repair in a cast, or more commonly now, a removable splint or brace. This is often positioned in approximately 90 to 110 degrees of elbow flexion and moderate supination, as this helps to reduce tension on the repair site in the early days.
And then rehab starts quite soon.
Yes, the rehabilitation process itself usually begins very early, often within the first week or two post-op, guided by the surgeon's specific protocol and the type of fixation used. It typically follows a phased approach. Phase 1, protection and early motion, roughly weeks 0-3. The primary goal here is simply to protect the repair while initiating very gentle, controlled motion to prevent stiffness. This usually involves passive elbow flexion and extension, often within a protected range set by a brace, and passive forearm supination and pronation.
Passive meaning the therapist moves the arm.
Exactly, or sometimes it's done with the assistance of a continuous passive motion CPM machine, or the patient uses their other arm to gently move the operated one. The focus is strictly on preventing stiffness without putting any active stress on the healing tendon. We also initiate gentle active range of motion for the shoulder and wrist right away to maintain mobility in the adjacent joints. Phase 2, intermediate motion and light strengthening, roughly weeks 3-6. As the initial pain and swelling subside, we gradually increase the range of active elbow motion where the patient moves the arm themselves. Light, isometric exercises for the biceps might be introduced where the muscle contracts without changing length, just to begin stimulating muscle activation without placing undue stress on the tendon repair site. We might also start with very gentle active supination against minimal resistance, like gravity. Phase 3, progressive strengthening, roughly week 6-12. This is where we start to gradually introduce more meaningful resistance. Light resistance exercises for both elbow flexion and supination are added, maybe using resistance bands, very light weights, or even gentle eccentric exercises under careful supervision. The progression is carefully monitored by the physiotherapist, ensuring there's no pain at the repair site. The goal here is to start building strength and endurance systematically. Phase 4, advanced strengthening and functional return, roughly weeks 12 onwards.
Now, over the next several months, as the tendon gains significant biological healing and tensile strength, the resistance exercises become progressively more aggressive. This includes both concentric and eccentric loading, heavier weights, and incorporating more functional multi-joint movements that simulate real-life activities. Patients are guided through work-specific or sport-specific drills by their physio or occupational therapist, gradually increasing the intensity and duration of these activities.
And patient adherence is key throughout this.
Absolutely imperative. Patients must adhere strictly to their surgeons and therapists' treatment plan. Since the biceps tendon can take, realistically, more than 3 to 4 months just to achieve substantial biological healing, and tensile strength and full maturation takes even longer, it is absolutely crucial to protect the repair by restricting heavy lifting, sudden forceful movements, and vigorous activity, particularly those involving eccentric loading or strong resisted supination for several months. We often advise against returning to very heavy overhead lifting or highly demanding contact sports or labor before at least 6-month post-op, and sometimes even up to a year is needed for full strength and confidence to return.
It's a long haul then.
It is undeniably a slow and progressive process, but the patient's commitment to their rehabilitation plan, their patience, and their diligent adherence to those activity restrictions are probably the single most important factors in achieving successful long-term outcomes and safely returning to all the activities they enjoy. Patients who try to push too hard too soon are definitely at risk of re-rupture or developing chronic pain and stiffness.
That really highlights the importance of the rehab pathway. It sounds like a truly collaborative effort as well, requiring seamless coordination across different disciplines. How does an interprofessional healthcare team typically work together to enhance outcomes for patients with biceps tendon ruptures? Right from that initial presentation all the way through to full recovery.
You're absolutely right. It embodies interprofessional collaboration at its best. Patients often first present not to an orthopedic surgeon, but to an emergency department, perhaps an urgent care clinic, or their primary care provider, their GP, or maybe a physician associate or nurse practitioner. The initial diagnosis, as we said, is primarily clinical, based on the patient's history and those key physical examination findings. For distal biceps tears, because of that critical time factor, a prompt referral to an orthopedic surgeon is absolutely necessary.
So the primary care role is crucial for speed.
Incredibly crucial. As we've highlighted, delayed treatment can lead to significant proximal retraction of the tendon and dent scar formation, which substantially complicates the repair and can negatively impact long-term functional outcomes. So, the primary care team's role in rapid identification and initiating that referral pathway is absolutely vital. Once the patient is referred, the interprofessional management team typically includes the orthopedic surgeon who performs the repair, dedicated nursing staff, both in hospital and sometimes in the community, and crucially, both physiotherapists and often occupational therapists as well. All these professionals must work collaboratively and communicate openly to optimize patient outcomes. For instance, nursing staff play a vital role in preoperative and postoperative education. They explain the procedure, manage pain expectations, reinforce wound care, and provide critical advice on injury prevention strategies.
Like the smoking cessation you mentioned.
Yes, exactly. Reinforcing the importance of discontinuing smoking is paramount, as we know smoking significantly compromises tendon healing due to its vasoconstrictive effects and impact on collagen synthesis. Nursing education on this, and also on things like incorporating stretching routines before physical activity in the future to improve tendon flexibility and reduce re-injury risk, is invaluable. Then the physiotherapists guide the patient meticulously through that progressive, phased rehabilitation program we outlined. They tailor exercises and activity progression based on the individual's healing rate, the specific surgical fixation used, and the patient's evolving functional needs. They constantly assess range of motion, strength, pain levels, and identify any compensatory movement patterns that might develop.
And occupational therapists, where do they fit in?
Occupational therapists often assist with adapting daily activities during the recovery period, providing strategies for managing tasks like dressing or household chores while the arm is restricted. They can also provide very specific work simulation or sport-specific training later in the rehab process, simulating the exact movements required for a safe return to their particular profession or sport. For most patients, achieving a high level of recovery, allowing return to basic daily activities, is often possible within 8 to 12 weeks. However, as we discussed, achieving true full strength and confidence for return to demanding work or sport often requires dedicated specific training over 6 to 12 months. This really highlights the interconnectedness of care required for optimal long-lasting results. It's truly a holistic approach that ensures every aspect of the patient's physical and functional recovery is meticulously supported by the whole team.
What a truly comprehensive breakdown of distal biceps tendon ruptures. From understanding the nuanced anatomy and the specific epidemiology, right through navigating the diagnostic challenges and making those informed treatment decisions, it's absolutely clear this is a condition that demands precise, coordinated care across multiple healthcare disciplines. As we conclude this discussion, what final thought or perhaps a provocative question would you leave our listeners with regarding the future of managing this condition? What's on the horizon that truly excites you in this field?
Well, I suppose I would encourage our audience, your listeners, to perhaps ponder the evolving landscape of tissue engineering and biological augmentation in orthopedics. It's a rapidly developing field. Given the inherent challenges we still face, particularly in chronic tears dealing with significant tendon retraction, that dense scarring, and the occasional need for extensive autograft or allograft material to bridge the gap, how might advanced biological therapies or regenerative medicine techniques truly revolutionize our ability to repair these complex injuries in the future?
So, moving beyond just mechanical repair,
Exactly.
Could we envision a day where we can perhaps stimulate the body's own endogenous tendon healing to a far greater degree? Maybe reducing the need for extensive grafts altogether, or even enhancing functional recovery beyond our current excellent surgical outcomes, especially in those challenging chronic cases where the native tendon quality itself is compromised. It's a really compelling area of ongoing research and clinical development, one that holds, I think, immense promise for moving beyond purely mechanical repair towards achieving true biological restoration of the tendon. That's quite exciting to think about.
in a truly thought-provoking perspective that certainly opens up fascinating possibilities for the future of orthopedic care. Thank you so much for sharing your invaluable expertise and insights with us today. This deep dive has undoubtedly enriched our understanding of biceps tendon ruptures and their management immensely. If you found this discussion informative and valuable for your practice, please do take a moment to rate and share this deep dive with your colleagues. It truly helps us reach more curious minds like yours right across the medical community. Join us next time for another deep dive into a topic that truly matters to your clinical practice.